Hello everyone. So let us continue with our discussion on abnormal uterine bleeding and its causes, the palm coin classification. We have already discussed about polyps, adenomyosis, leiomyoma, or uterine fibroids, and have begun our discussion on gynecological malignancies. And in gynecological malignancies, we have discussed about endometrial cancer and cervical cancer. So, if you have not watched these previous videos, I would request you to watch them in series sequence so that you get a better understanding about the topic. So, as we are continuing with our discussion on gynecological malignancies, today's topic of discussion is ovarian cancer. So, before we proceed further, let us quickly go through the functions of the ovary, like what happens inside the ovary in the 28-day menstrual cycle. We have already discussed this in our previous video. Today, we'll just have a quick revision. So here we can see the maturing follicles. This is during the first 14 days of the menstrual cycle, we can see the follicles developing. These follicles secrete estrogen, which is responsible for building up the endometrial lining. On the 14th day, the matured follicle, like there is rupture of ovum from the matured follicle. If the ovum is fertilized, okay, the follicle later on regresses into corpus luteum. If the ovum is fertilized and pregnancy occurs, the corpus luteum secretes progesterone, which helps to maintain the pregnancy. And if there is no pregnancy, the progesterone secreted by the corpus luteum brings about secretory changes in the uh, endometrial lining. All right. And after the completion of 28 days, there is sudden withdrawal of progesterone, which brings about the menstrual bleeding. Ovarian cancer is the seventh most common gynecological cancer in women worldwide. So, even though it is the seventh most common gynecological cancer, it is the most notorious form of gynecological cancer because of its non-specific symptoms, and due to the non-specific symptoms, it is diagnosed at a very late stage. Okay, it's diagnosed at a later stage. We shall be discussing about it in depth in the uh, further slides. All right. So, over 239,000 women are diagnosed with ovarian cancer worldwide each year, and about 140,000 women die from the disease each year. So it's a very big number. That is why ovarian cancer is considered as one of the most notorious form of gynecological cancer. Ovarian tumors are primarily divided into three types. Okay, these are the types of ovarian tumors. We have epithelial ovarian tumors, germ cell tumors, and sex cord stromal cell tumors. We shall be discussing about each type briefly. Now we are talking about epithelial ovarian cancer. Now, epithelial ovarian cancers constitute about 90% of all ovarian cancers. So, when we are talking about ovarian cancers, about 90% of them are epithelial ovarian cancers. Okay, they form the majority of ovarian cancers. It arises from the mesoepithelial cells of the ovarian surface. They are mostly bilateral in origin, and the age of occurrence is 60 to 70 years of age. So it is very commonly seen in the elderly women due to the non-specific presentation, leading to delay in diagnosing the disease. I've already mentioned about the non-specific presentation. Usually the woman may not even experience any kind of symptoms related to the reproductive organs. The symptoms that she might be experiencing will be dyspepsia, abdominal bloating, retrosternal burning, that is chest burning, and she might be under the impression that I have some gastrointestinal issues, I have some acidity issues, indigestion issues, and they usually seek care, primary care for such symptoms, and they are given medications also according to these symptoms. Hence, the ovarian tumor is usually left undiagnosed because, like, she might not be even experiencing any kind of reproductive symptoms, like no significant pain around the ovarian region, no significant menstrual abnormalities. She might be menstruating fine. There might be some issues, but it is not significant enough to seek care, seek medical attention. So, the ovarian cancer, it stays, there. It keeps developing, and all this leads to diagnosing the disease very late, and then by that time we diagnose the disease, it has extensively spread, leading to a difficult management, and hence this all this chaos leads to a very poor prognosis. Okay, and another very important thing to note is that the most common route of spread is via tumor exfoliation. Now we shall see what this tumor exfoliation is in the next slide. Now, what is tumor exfoliation? Now, we are familiar with the skin cells exfoliating, dead skin cells exfoliate. Similarly, we have these tumor cells, the malignant cells that exfoliate. Okay, they fall from the primary side, they exfoliate and fall into the peritoneum. Where do they exfoliate? They exfoliate into the peritoneum. Okay, so the tumor cells are going to exfoliate from the surface of the ovary, leading to microscopic cells, okay, seeping out into the peritoneum. This will lead to faster and rapid spread of the tumor to the adjacent pelvic and peritoneal structures. So we have seen that the epithelial ovarian tumors are usually bilateral in origin. Okay, that is primarily because of this exfoliation. It is very quick for the tumor to spread into the adjacent ovary. All right. Now let us see the subtypes, the histological subtypes of epithelial ovarian tumors. So we have primarily serous tumors that accounts to 75% of all epithelial ovarian tumors. One very important thing to note is that the most common type of ovarian cancer is the serous cystadenocarcinoma. Okay. Secondly, we have mucinous tumors, which accounts to 10% of all epithelial ovarian tumors. Then we have the endometrioid tumors, which accounts to 8 to 10% of epithelial tumors. And again, we have clear cell tumors and Brenner tumors that are rarely seen. Okay, they are the rare subtypes of epithelial ovarian tumor. Now let us discuss about the second type of ovarian tumor, that is the germ cell tumor. Okay, so previously we discussed about the epithelial ovarian tumor. Now we are discussing about germ cell tumor. Now germ cell tumors account for 3 to 8% of all ovarian tumors. So when we make a comparative study, epithelial ovarian tumors, they constituted about 90% of all ovarian tumors. So here we have germ cell tumors, which account for about 3 to 8% of all ovarian tumors. Okay. The age of occurrence is 10 to 35 years. Again, an epithelial ovarian tumor, the age of occurrence was 60 to 70 years. So epithelial ovarian tumor was commonly found in the elderly women, elderly population. But here in case of germ cell tumor, it is usually found in the young female population in their reproductive age group. Okay. Uh, so even though out of the 100% of ovarian tumors, germ cell tumors account only 3 to 8%, but when we take about their occurrence in young female population, like below the age of 20 years, 60% of the tumors are of germ cell origin. Okay, so if we come across ovarian tumor, okay, a young woman has developed ovarian tumor below the age of 20 years, almost 60% of time it is going to be germ cell tumor. Okay, so majority of the tumors are benign. Now, even though most of the tumors are benign, the tumor found in girls under 10 years of age, so almost 85% of ovarian tumors belong to germ cell group and are almost always malignant. So under 20 years of age, almost 60% of all ovarian tumors were germ cell in origin. And below 10 years of age, we have 85% of the ovarian tumors usually belong to germ cell group. Okay. They are usually unilateral. So when we compare it with epithelial ovarian tumor, it was usually bilateral. Now, here in germ cell tumor, they are usually unilateral. They are diagnosed early. Okay, there it was diagnosed very late due to the non-specific symptoms which we discussed. Here in germ cell tumors, they are diagnosed early. Okay, as they grow to large sizes, leading to stretching of the ovarian capsule, which in turn produces pain. So, pain, it produces pain and some related symptoms. That is why it is diagnosed early. So, these things help in early diagnosis. Now let us discuss about the types of germ cell tumor. Okay. First we have is teratomas, dermoid cyst, also called as mature cystic teratomas. They are the most common germ cell tumor. Now when we talk about tumor, it could be either malignant or either benign. Okay. So dermoid cyst, or it is as it is also called as mature cystic teratomas, they are the most common type of germ cell tumors, and they account for 5 to 10% of all cystic tumors of the ovary. Next, we have is dysgerminoma, which is the most common germ cell cancer. This is 100% malignant. Okay, so dysgerminoma is the most common germ cell cancer, and dermoid cyst is the most common germ cell tumor. Uh, the most common type of germ cell cancer is dysgerminoma, and it accounts for 3 to 5% of all ovarian tumors. Dysgerminoma usually arises in young women or children, with the average age of incidence being 20 years of age. And we also need to note that even though germ cell tumors are mostly unilateral, like the characteristics of the germ cell tumor group, which we discussed in the previous slide, they were mostly unilateral, found in younger population. But dysgerminoma could be an exception. Okay, dysgerminoma can be bilateral as well in about 15% cases. Okay, next we have endodermal sinus tumor, embryonal carcinoma, and choriocarcinoma. These are all very aggressive tumors and are almost always unilateral. The third type of ovarian tumors was sex cord stromal cell tumors. Okay, here the average age of occurrence is 40 to 50 years. In epithelial tumors, it was 60 to 70 years. Germ cell tumors, the reproductive age group 10 to 30 years. In sex cord stromal cell tumors, it is 40 to 50 years, usually unilateral. Again, epithelial, it was usually bilateral. In germ cell tumors, it is similar to sex cord stromal cell tumors. It is usually unilateral. Again, similar to germ cell tumor, it is diagnosed early and it has a good prognosis as it is diagnosed early. Okay. Now coming to the histological subtypes of sex cord stromal cell tumors. First we have is granulosa stromal cell tumors. Granulosa cell tumor is the most commonly encountered sex cord tumor. They secrete estrogen, hence are associated with abnormal uterine bleeding, postmenopausal bleeding, and endometrial hyperplasia. So excessive estrogen, we have already discussed in the topic of endometrial cancer. Excessive estrogen leads to endometrial hyperplasia, which leads to all kinds of menstrual problems. Okay. Next, we have the other types that are theca cell tumors and Sertoli Leydig cell tumors. They produce androgens. Androgens are the male hormones. Okay, your granulosa stromal cell tumors, they produce estrogen. Theca cell tumors and Sertoli Leydig cell tumors, they produce androgens, which lead to virilization. Virilization is the development of masculine physical traits in a female. So, as we have already discussed, out of all ovarian cancers, epithelial ovarian cancers account for 90% of the ovarian cancers. So, we shall be discussing about epithelial ovarian cancer in detail. Now, let us discuss about the risk factors for epithelial ovarian cancer. So, the risk factors include nulliparity, early menarche, and late menopause. Now, if you remember, these were the risk factors for endometrial cancer as well. Nulliparity, early menarche, and late menopause. And there we discussed that why are these risk factors for endometrial cancer? Because of excessive estrogen exposure. Okay, because during pregnancy, during lactation, a woman is free from that estrogen exposure from ovulation, and a woman who has never bore a child, who is nulliparous, who has longer reproductive lifespan, that is who has attained early menarche and who is going through a late menopause, they have increased rate of mitogenic activity of the epithelial cells of the ovary, and they are again and again exposed to estrogen. That is why these are considered as the risk factors for epithelial ovarian cancer as well as endometrial cancer. Next we have is increasing age, delayed childbearing. Now talking about the signs and symptoms of epithelial ovarian cancer, we have already discussed that the signs and symptoms are very much non-specific, not even related to, most of the time, not even related to reproductive organs, and most of the time they present as gastrointestinal symptoms. So we have dyspepsia, abdominal bloating, fullness in the abdomen, increased urinary frequency or urgency to urinate. Now, these could be related to the pressure symptoms, okay? Constipation, increased urinary frequency, increased urgency for urination. These are usually the pressure symptoms. When the tumor grows in size, it exerts pressure to the adjacent organs. So we have adjacent organs are, we know, urinary bladder, rectum, colon. So it leads to increased urinary frequency, urinary urgency, constipation. Other signs and symptoms include menorrhagia. Menorrhagia is not very particularly seen in epithelial ovarian cancers, but is very commonly seen in granulosa and theca cell tumors. Now, the reason behind which we know, because of excessive, these tumors produce estrogen. Okay, estrogen leads to uh, increased endometrial proliferation and abnormal uterine bleeding. Okay, so that is why we can see menorrhagia usually in granulosa theca cell tumors. Postmenopausal bleeding, again, not a common feature seen in epithelial ovarian tumor. We can see it in Brenner tumor. Okay, urine retention, again, I told you that the pressure symptoms could lead to urine retention as well. Abdominal pain, commonly seen in germ cell tumors. That is because of the stretching of capsule of the ovary. Okay, that is the reason it causes abdominal pain. Abdominal pain, again, is not a very particular uh, symptom seen in epithelial ovarian cancer. It's usually seen in germ cell tumors. Now let us talk about the gene mutations seen in ovarian cancer. So the gene mutations seen are BRCA1, BRCA2, and HNPCC gene mutations. In BRCA1, mutation is carried in chromosome 17q. In BRCA2, mutation is carried in chromosome 13q. Now, HNPCC gene mutation is associated with Lynch syndrome. Lynch syndrome is often called uh, hereditary non-polyposis colorectal cancer. Okay, it is an inherited disorder that increases the risk of many types of cancer, particularly cancers of the colon, rectum, which are collectively referred to as colorectal cancer. People with Lynch syndrome also have an increased risk of cancers of the stomach, small intestine, liver, gallbladder ducts, urinary tract, brain, and skin. Additionally, women with this disorder have a high risk of cancer of the ovaries, which we're talking about now, and also the cancer of lining of the uterus, that is the endometrial cancer. So HNPCC, that is the hereditary non-polyposis colorectal cancer, usually associated with Lynch syndrome. Okay, these are the gene mutations that we usually see in ovarian cancer. And one very important thing to notice, BRCA1 and BRCA2 gene mutations are also seen in breast cancer as well. Now let us see what are the complications associated with ovarian tumors. First, and one of the most common complication, is torsion. So torsion is one of the commonest complication of ovarian tumors, and again very common in dermoid cysts, as the contents of the tumor make it heavier. So dermoid cyst, we have already seen, it is the most common form of germ cell tumor. So torsion is very commonly seen in cases of dermoid cysts. Okay, as the cyst usually contains cheesy sebaceous material and foci of calcifications called the Rokitansky protuberance, making it heavy and easy to undergo torsion. Next we have is rupture. Rupture could be either spontaneous or traumatic. Now, after torsion and rupture, the next complication is hemorrhage. Next we have is infection, pseudomyxoma peritoneum, and malignancy, that is development. A tumor could secondarily develop into malignancy. Now, what are the investigations usually done in cases of ovarian cancer? Primary investigation is ultrasound. Ultrasound, most probably transvaginal ultrasound, which will give us detailed features of the tumor, which usually helps in diagnosing the ovarian cancer. Okay, benign tumors are usually unilateral, and malignant tumor is suspected if the ultrasound reveals bilateral or a solid tumor with ascites. Next, we have a CT scan and MRI. Now, CT scan will guide us with lymph node involvement and if there are any abdominal deposits. Now, CT scan, MRI, they usually don't help us with the diagnosis. We can diagnose with ultrasound and the clinical examination as well. What does CT scan and MRI help? They help plan the surgical management. Okay, so if the tumor, the cancer, is extensively spread to the abdominal organs, other organs, so we need to involve a gastric GI surgeon into the case. So it will help in planning the surgery, okay, along with post-operative radiotherapy or chemotherapy. Next we have is color flow Doppler. So color flow Doppler technology adds further information of neovascularization. That means it reveals any increased blood flow to the tumor and the probability of the tumor being malignant. Now, other investigations include tumor markers such as CA125 and CEA, that is carcinoembryogenic antigen. Now, again, these tumor markers do not contribute in making a diagnosis. Okay. For example, if CA125 is raised, it does not mean that the woman 100% she has ovarian cancer, because it can be raised in abdominal tuberculosis or pelvic endometriosis as well. So, what do they help? They help in following up after surgery or chemotherapy and keep a track of the response to treatment. Hence, we need to achieve a baseline level of these tumor markers before surgery or initiating chemotherapy or any kind of treatment so that we can follow up later. Next is cytological study of the ascitic fluid or aspirated cyst fluid. Now, the cytological study of the ascitic fluid or aspirated cyst fluid, either laparoscopically or under ultrasound guidance, may reveal malignant cells. However, high incidence of false negative reporting is also noted. Now comes the management part. Now, how do we manage these ovarian tumors? So, a simple unilocular cyst less than 7 centimeter is often a functional cyst and should be observed. Okay. So we know ovary, inside the ovary, there are constant cell changes, constant activity that is happening according to the menstrual cycle. So then the a simple unilocular cyst if noted, which is less than 7 centimeter, we can observe it. We don't need to directly intervene. Okay, surgery, this, that. Most functional cysts resolve spontaneously over 4 to 5 months, and we offer timely follow up and a repeat ultrasound. So, the repeat ultrasound will identify a persistent cyst or if the cyst is growing in size, which will then require further intervention and removal. So, simple unilocular cyst less than 7 centimeter, we observe, we ask the woman or the girl to come for timely follow-ups, and we can follow up with ultrasound after 6 months and observe if the tumor is resolved or the tumor is growing in size, and later on we can plan how to manage it. Now, a benign ovarian tumor, okay, uh, of more than 7 centimeter in size will require removal, surgical removal, due to its potential for transitioning into a malignant tumor, and also due to the potential complications, okay, which we've already seen: torsion, rupture, hemorrhage, infection, etc. Okay. Next we have is surgical staging. Surgical staging with the help of laparotomy are advisable in cases of early stage tumor. Next is cytoreductive surgery or debulking surgery. Cytoreductive surgery or debulking surgery are recommended in cases of advanced stage cancer in which all possible tumor tissues are tried to be removed. Optimal debulking surgery is when less than 1 centimeter of residual tumor is left in the body. Now, after surgical staging, after depending upon the stage of the disease, your doctor will further advise radiation, chemotherapy, or observation follow up. It is highly case specific and according to the advice of the doctor. So stay tuned, everyone, as we will be continuing with the discussion of abnormal uterine bleeding in our upcoming videos. Do consider to like, share, and subscribe to the channel if this information was useful to you, and follow me on Instagram for more such helpful health related topics. Thank you.